Welcome, everyone. It is 1 o'clock. We're going to proceed with getting started with today's webinar. My name is Heather Brandt. I'm a longtime member of the National Colorectal Cancer Roundtable, and I've also been part of the Roundtable's Evidence-Based Education and Outreach Task Group for several years, and I want to thank you very much for joining. We've had a lot of interest in this topic and other topics related to increasing colorectal cancer screening, and very much appreciate you taking time to join us today. So to get started, I wanted to run through the purpose of today's webinar. So the purpose of today's webinar is to review evaluating systems change initiatives using the 7 steps to evaluation that are outlined in the National Colorectal Cancer Roundtable's Evaluation Toolkit. And the toolkit's title is How to Evaluate Activities Intended to Increase Awareness and Use of Colorectal Cancer Screening. So hopefully that's a resource that you're familiar with, and if you're not familiar with, that you will check out later today after listening to the webinar. Systems change initiatives play a key role in helping us to reach colorectal cancer screening goals, but many of us have a lot of questions about how to most effectively evaluate these initiatives, that they can be a lot more complicated and complex than some of the other evaluation work that we do. And so in order to answer these questions, using the 7 steps to evaluation, we're going to have those guide us through this process and help us understand how we can use evaluation results to improve and inform our program work. We're going to do this by looking at the Ohio Academy of Family Physicians Colorectal Cancer Screening Improvement Program as one example, and explore how this program may evolve their evaluation approach to consider key questions about systems change. And so with that focus in mind here today, I'm going to take you through some of these key questions. So looking at the program itself and what does the program entail, what have been the results of the current program and current evaluation, how has the program used the current evaluation results as a form of continuous quality improvement and feedback, how can the program adapt its evaluation to focus more on these system level changes, and how can the program use results to inform and improve its work. And hopefully along the way, all of us will be able to obtain additional information that will help inform our evaluation work. So as I mentioned, my name is Heather Brandt. I'm the moderator for today, and I want to run through a few pieces of information about our speakers who will be joining us today for the webinar. So first we have Nick Stuber. He's a research associate at Wilder Research, and he will explore with us how the program can be adapted, how this Ohio-based program can be adapted in its evaluation work to focus on long-term and systems-level impact. But first we're going to hear from Kate Mailer, the Deputy Executive Vice President at the Ohio Academy of Family Physicians. And she's the one who's going to share with us about her experience with the Ohio Academy of Family Physicians Colorectal Cancer Screening Improvement Program and the types of evaluation that they're working on. And so just a few things to run through before I turn this over to our speakers today. We are recording today's webinar, and the replay and speaker slides will be shared with you in just a few days. And because of the large number of participants, all of you are muted on today's webinar. And having said that, we still want to make sure that you get what you need out of the webinar. So we encourage you to ask questions by submitting your questions through the webinar question and answer function. In your screen, you should see a box in the lower right-hand corner. That's where you can type in your questions. You can actually type them in at any point during the webinar, and those questions will be put into a queue and addressed at the end of the webinar. We also will be emailing responses to questions that we don't have time to get to during today's webinar. And you're also always welcome to email us with questions after the fact that may arise. We are asking for your help in evaluating the webinar as well. You'll be receiving an email with a survey link So please take just a few moments to help us out with feedback, what you liked, what you didn't like, and how we can improve, because we are big believers in the importance of evaluation. So with that, I am very pleased to turn the webinar over to Nick, who's going to give us an overview of the National Colorectal Cancer Roundtable Evaluation Toolkit and start us off with the 7 steps to evaluation. So I'm going to hand this over to Nick, so please take it away.
Thank you, Heather. And this is a picture of the evaluation toolkit that Wilder helped develop with the National Colorectal Cancer Roundtable. Some of the information that we'll be referencing in today's webinar is available through the evaluation toolkit, which is available through the National Colorectal Cancer Roundtable website. The toolkit itself has sample evaluation tools and tip sheets available that cover all the major steps of the evaluation process. The toolkit is currently undergoing an update to include more references to policy systems and environmental change. So look for that updated toolkit, or look for that update rather to the toolkit, which will be coming out soon. And then, as Heather mentioned, we're going to be using the 7 steps to evaluation, or referencing them rather, throughout the presentation today. We found that these are helpful to ground us in the key components of the evaluation process. And then you'll see us reference these more so in the systems portion of the presentation today. So with that, I'm going to turn it over to Kate, and she will give an introduction to the Ohio Colorectal Cancer Screening Program.
Hi, everyone. Thank you so much for having us. As Nick had introduced me, I am the Deputy EVP for the Ohio Academy of Family Physicians. Our organization is a state chapter of the American Academy of Family Physicians and considered one of the largest. We have about 4,400 members, which are all family physicians, family medicine residents, and students. But we're very excited about this particular program, as it's been a kind of a shining star for our membership. I found this photo on a blog that had about 60 images of the past 100 years, and I must have been thinking about the Ohio Colorectal Cancer Screening Improvement Project at the time, because I see a correlation. Like this picture of Sweden's first morning after changing their law of which side of the road to drive on, making improvements in medical practice is hard and often leads to confusion and frustration. However, today I'm going to share with you a snapshot of a quality improvement initiative that strengthens teamwork, communication, and most importantly, improved health outcomes, hopefully without the traffic jams. Sorry, I'm trying to, oh, great. So just to kind of give you a framework for our project aim and our partners, the Ohio Colorectal Cancer Screening Improvement Project has been a collaborative effort between national, state, and local organizations. Without the help from the American Cancer Society, the Ohio Department of Health, and the New Jersey Academy of Family Physicians, the OAFP would not have been able to sustain such a rigorous and successful program. We added the Ohio Association of Community Health Centers just last year, and they helped us with recruitment assistance of their member practices, and which has proved to be a terrific asset to our success. And we look forward to engaging these groups for ongoing support. And as I'd mentioned, this has been a priority program of the Ohio Academy since 2008. And to kind of give you an idea of our program, it's best to kind of describe this in 2 parts, as a 2-part intervention. First, the practice team training day, and second, the data collection, analysis, and outcome reporting. Annually, practices are selected to participate in a unique quality improvement training session to customize an office protocol, to properly identify patients at risk for colorectal cancer, and when to recommend appropriate screening. By utilizing the skills of the entire office team, the system developed during the team training day helps to streamline the referral for procedural process that improves patient care while increasing physician payment and office efficiency. It's important to note that the attendees of the team training day is not focused strictly on physicians, but more importantly on the entire team. So those that are coming to this meeting are nurses, MAs, PAs, front office staff, and of course a physician. All participating practice teams are required to engage the Colorectal Cancer Screening Improvement Module, which serves as our data collection and project analysis instrument. The online professional development tool is designed to be user-friendly, interactive, and help incorporate quality improvement initiatives into the practice. Through this process, practices identify areas of practice strengths and opportunities for improvement through the collection of patient and practice data. The module helps develop a QI plan, implement interventions, and complete a post-assessment process to determine if improvement was achieved. The data collection and practice assessment module is housed on the New Jersey Academy of Family Physicians website, and I believe on the right-hand side in red, that is the website address. Once the practice is completed the required phases of the module and determined that their practice intervention for improvement, team members created an action plan that serves as the impetus for the team training day activity. And to elaborate a little bit more on the practice team training day, I wanted to give you kind of a brief overview of what our teams experience. Each year we recruit up to 20 practice teams from across Ohio, and those teams represent rural, urban, solo physician, large health system physician teams, and community health centers. We promote the benefits, free registration for up to 3 members of their teams. We reimburse them for their travel expenses to get to the meeting. And then we also offer prescribed CME credit, which is available to all members of the care team. And then, of course, the topics that we talk about, the importance of team engagement. We review the ACS Toolkit and action plan, setting office reminders, tailoring protocols, and one of our really favorite activities is a hands-on workflow and process mapping exercise. The next slide just gives you a brief overview of some of the sample resources that we provide. You'll see some very familiar materials that we're very happy to use and promote to our member teams. But there's one of the best, I guess, benefits of participating in the team activity is a mapping exercise. And there really is the benefit to doing that is because you can map out and record a process step to improving the patient's colorectal cancer screening outcomes. It's a visual display which allows everyone to see what role and contribution their colleagues make to the overall goal and creates appreciation for what their members of the care team can do. The process map allows everyone to see their work in the context of the overall process, which increases staff satisfaction. This exercise allows the team to see where work backs up, where work can be standardized and improved, patient flow, workflow, and to identify problem areas that can be tweaked for maximum efficiency. What's nice is that we do this on the large format so that those in attendance can take it home with them and share what they've learned in the new protocol with those that weren't able to attend in person. So our second portion of this system is our data collection module. It's a systematic approach to identify areas of practice strengths. You'll see that there's a practice assessment, an action phase, and a post-assessment phase. Step 1 has many parts. The patient data collection portion is where the physician's instructed on how to select charts to use for data collection. And they will then learn how to enter pre-assessment patient data by entering a series of questions designed to capture information specific on evidence-based performance measures. Within that first phase, they do a practice assessment, and they'll be asked to answer questions that provide insight into their practice's delivery, decision support, and clinical information systems. Once they have entered those data points, there's an interpretation of results. At that point, their measurements are displayed, which is their baseline data, and then it will be a kind of a guiding point for them to select an intervention directed at improving care processes within their practice. They are then asked to select a quality improvement plan, and in that section, the physician will be provided a number of options for quality improvement that can assist them improving areas of their practice. The plans then provide suggested QI goals, changes to implement, steps to change, and ways to measure their success. The second portion is really what it says, the action phase, and it's a 3-month period for the practice to put their change into effect. After that time, the physician can then come back to the module and enter their post-assessment data. The step 3, which is the post-assessment phase, is basically replicating all parts of the baseline measurement, including the practice assessment, the patient charts, and the analysis of results. In this final stage, the module helps interpret overall results and evaluates the quality improvement plan. The physician's given the pre- and post-assessment measurement results, as well as information about the effectiveness of the intervention and processes implemented as part of their quality improvement plan. The data collection module has been accredited both by the American Academy of Family Physicians as well as the American Board of Family Medicine for maintenance certification. And I have to share with you, CME credit is great. It's plentiful and it's out there, but what is really the carrot for our physician teams to participate is that maintenance certification Part 4 credit. Those activities are not, they are available on the ABFM website, but for the most part, creating a module of this magnitude is very expensive. So providing an opportunity for free for teams to participate and gain that valuable credit is really a nice carrot to participation. And of course, we do have to have human beings behind the module, and both the OAFP and the New Jersey Academy have staff to help any of our teams get through their module and help earn that valuable credit. So I have a few years of project outcomes to share. For 2014, overall the improvement is quite remarkable. If you assume the samples are of equal size, the basic average for improvement for all the practices that completed the program in 2014 averages a 60% increase in colorectal cancer screening rates. One of our practices could not be included in the overall improvement percentage because their baseline measurement was 0, and the practice improvement was infinitely or unmeasurably better. Our 2013 results, as in 2014, proved to be quite successful. Again, if you assume the samples are of equal size, the average improvement for all the practices that completed the program in 2013 averaged a 60% increase in colorectal cancer screening rates. So for all of you at home keeping score, that's 2 years of improving colorectal cancer screening improvement rates by by 60%. Program evolution. The purpose of this project is to improve the care. Currently, we are updating the New Jersey module for the colorectal cancer screening improvement. We are expected to finish that process December of this year. We're just fine-tuning a few that we have identified over the years and should make usability a little bit more high-functioning. In May of this year, we are going to be launching a new module based off the learnings that we have found through the colorectal cancer module centered on breast and cervical prevention and early detection. And then in 2016, we will be building a new type of team training experience and allowing practice teams to select a track, one towards colorectal cancer screening improvement and the other one about breast and cervical cancer. And the purpose of the project to improve the care women receive related to detection and treatment of breast and cervical cancer is really the impetus for this new module. It's a very important topic for primary care physicians, and we are very excited to take our learning and expand it into another area of cancer prevention and detection. I just wanted to leave you with my contact information in case you have questions or would like additional materials. I'm happy to share those with you. And we'll be on the line later for any questions that you might have. At this point, I'm just going to pass the baton to Nick.
Thank you, Kate, for that overview. And I'm going to just briefly touch on the current evaluation questions that the Ohio Academy was using to evaluate their program. And I'm not going to run through all the questions, but just highlight at a higher level that their questions are really about what is the knowledge that practices gain from taking part in the program. And then the overall other larger question really related to this, what is the impact on colorectal cancer screening rates as a result of taking the program? And as Kate mentioned, she highlighted the pre and post CRC screening rates and the success that they've had there. The other piece that I'll highlight is that they did survey the practices after the in-person training and found that across the board, on average, people reported increased knowledge in terms of all of those key components of the training that Kate was also highlighting in her introduction. And then these are just some of the pieces of how the Academy is using their current evaluation findings. A lot of it is to really build the case for the program, which, as Kate said, the model has been duplicated into other screening efforts, and also just to talk about the program through some of the reporting that they're doing as well. So we're now going to transition into future evaluation interests that the Ohio Academy of Family Physicians has, and it's one in which they want to focus on the long-term and systems-level impacts of their work. And before we return back to the screening program, I just want to take a little bit of time to introduce the systems change concept. So first, it's important to note that systems change is an incredibly complex topic. There is a rich literature available about systems theory and approaches to evaluating and researching systems and systems change. And if you are interested in that, you can easily fall down the Google rabbit hole researching information on that. So have at it. However, for this webinar, we're presenting a more straightforward definition. So put very simply, systems change is a change that impacts all aspects of an organization, institution, or system. And so you might be asking yourself, well, what constitutes a system, or what are some examples of systems or a system? And systems can really operate at two levels. They can operate at an organizational level or as part of a network or grouping of organizations or institutions. So at an organizational level, a system change could impact the procedures and processes of an organization. So this would include things like resource allocation, staffing, programming. Just a quick example is if an organization passed a policy that allowed people who work there to take work time, paid time to get screened for colorectal cancer, that would be an actual policy change, but the results of that would have some sort of systemic impact on the organization in terms of their staffing, in terms of their resource allocation, in terms of their practices and benefits surrounding work and wellness as well. And then systems change could also operate at this higher level. So for example, a group of clinics or service providers working together to provide a health service, they could coordinate their services, they could share learnings and responsibilities, they could also have similar financial incentives or motivations as well. And then the other piece that I just want to point out is that systems change can work in tandem with policy changes. So when we think of policy systems and environmental changes, the P and the S part of that can work together. So a large-scale example would be the Affordable Care Act, which ushered in major federal policy changes, but also fundamentally impact the system of healthcare delivery in the U.S. And then when we think of colorectal cancer screening, there are a few systems that come to mind, and some of them are listed here. So hospitals and clinics, nonprofit health organizations, associations, public health, and government. So there are a few key aspects of systems change that are worth pointing out. Systems change is really looking at altering or impacting the way an organization, institution, or group of organizations operates. So it's about changing the operational environment that exists. In contrast to a health promotion strategy or a health program that is focused solely on an individual and changing that individual's behavior. The piece that I will underscore is that programs focused on individual health and interventions focused on systems change initiatives can have the same end goal or long-term outcome. So, for example, ultimately reducing colorectal cancer incidence and mortality. The key piece, though, of systems change is that they're designed to move really beyond or above the individual level by focusing on the broader environment and then how that individual interacts with that environment. Systems changes are also foundational in that they're designed to impact the core elements or practices of an organization or network of organizations. They're also meant to be long-term and sustainable. So these are not meant to be short-lived program types of interventions. So there's a focus on changing practices, policies, procedures that will have more of a profound and long-lasting impact. So when you were thinking about whether an intervention is systems-based, so these are some of the key elements listed on this slide that you could think about when you're looking at a logic model or theory of change or just thinking about programming in general and various types of interventions. So to bring it back to the Ohio case, that screening improvement with the Ohio Academy of Family Physicians Screening Improvement Program, staff are now interested in thinking about measuring the impact of the program's work on the system of family medicine practitioners that are engaged in colorectal cancer screening. The other interest they have is seeing how the Ohio Academy of Family Physicians organizational system, its internal one, is also being impacted as a result of this work. So how is its training and education work being fundamentally influenced by the work of the program? And so this graphic here just really illustrates the multiple systems that are at play. So in the middle we have the Colorectal Cancer Screening Improvement Program and that blue dot. But you can also see that that operates within the Ohio Academy of Family Physicians, and the services that the screening program are delivering are directed at the Ohio Family Physicians practices, so that system in the green. And then all of this is really operates within the Ohio public health system as well. And we could keep going and going with the multiple systems here as well, listing, for example, a federal sort of system that could potentially be at play. And so the point of this graphic is to just illustrate that there are multiple systems at work, and there's often overlapping interests and impacts that are going on as well. So what the Screening Improvement Program is interested in, though, is what are the impacts that are happening at these various levels, and how can that guide the evaluation moving forward. So now we're going to go through sort of the first step in the 7 steps to evaluation that I mentioned at the beginning. And again, this is also noted in the toolkit. So the first step is to map your program or intervention. And we're going to start with a program intervention and then compare that to more of a systems-based intervention. So in this program intervention, we have a colorectal cancer education screening program. And of course, just like any good logic model, we have our inputs, our activity, and then our outcomes, both short, intermediate, and long-term. And this one is focused on patients gaining knowledge about screening, patients making an appointment, and then ultimately screening rates increasing. So the key piece here is that this is all directed at individuals, an individual level change. That's sort of the key takeaway from this image. There are no changes of sort of practices or procedures or environments going on here. It is really the individual is the unit of focus. And then it's also not depicted here, but this program could potentially be short-lived, or it may not be created with sustainability in mind. And so those are some of the other features that differentiate the program-level intervention versus more of the systems-level piece. So now we'll transition to looking at more of a systems intervention, and this one is a condensed model of the Ohio Colorectal Cancer Screening Program. And you'll see the boxes here. They're similar in terms of outputs, naming the actual activity or intervention, and then the outcomes as well. But really, this is operating at a level higher than just the individual. And so you'll see that the intervention is the program itself. The outcomes is practices adopting new or updated protocols that have the evidence-based strategies in order to increase colorectal cancer screening. More of the intermediate program is the changes that the practices put into play. And then the long-term one is really asking, are those changes sustained, which is a key feature of looking at more of the systems-based level. And then the other piece that I just want to point out as well is that the inputs may include multiple stakeholders, which is another feature of the systems level change. So it's often a complex mix of different people who are helping to put this intervention in play, and then may also be affecting it as well. The program itself is directed at a larger group, in this case a system of family physicians within Ohio. And then these are all organizational level changes, which is the other key difference here as well. And then the other piece that I'll point out, again, to take us back to that circle graphic, is that there are multiple systems at play as this intervention is going on as well. And so that's another key piece that is important to have in mind as we're looking at this work. So there are different things that you could focus on as part of a systems intervention that differ from program intervention. Program intervention focuses really on the individual, as we showed through the logic model, particularly looking at things like satisfaction, participant satisfaction, individual increases in knowledge and awareness, individual behavior change. These are some of all the key pieces when we're looking at colorectal cancer screening programs directed at the individual that we're interested in measuring. Systems change is focused really on answering the process and outcomes questions around evaluation. So a system change is going to influence the practices and procedures for an organizational system or network of organizations. The sustainability of the systems change is critical to measure and ask about. And then, it's important to remember that, of course, that these are intended to last for a long time or to have longevity once they're implemented. And then questions and measurement of this feature is critically important. And then, in addition, any modifications to the system should be tracked and measured. So these modifications can yield important information about how systems change is sustained and specifically adapted to different organizational contexts. And then the information captured from this could be of great benefit to those who are also involved in the work. And then, lastly, asking about the intended and unintended consequences of systems change intervention will help you track the various ripples of the changes and potentially uncover some outcomes that were unanticipated as well. And then the other piece that I'll mention too, and it's not noted on this slide, but systems change work can also result in the building of new relationships or new connections. Often this work is supported by a coalition or organization of individuals or different groups, and so it might be, if that is a change that you're interested in measuring, focusing on those relationship changes as well. So going back to the Ohio program, using more of the systems lens, we can think about potential future evaluation questions. And so here are some listed up here, but thinking roughly, after a year of participating in the program, the practices that have taken part of it, have their colorectal cancer screening protocols been maintained? Have those changes to their organizations been maintained? And then what modifications, if any, have the practices applied to the protocols? Have the practices applied their protocol to other areas of health screening? And if so, what areas? And then what have been practices' overall key successes and challenges to using their screening protocol? And are there any lessons learned that can be shared back with the entire network around that? And then some of the even higher level questions that could be asked to focus on really how is the program influencing the state health system, and looking at how it's also influencing the Ohio Academy of Family Physicians itself and its own internal work that's going on around education and training. So have there been changes to practices or procedures, and then if so, how have these been implemented and received? And so some of the key observations from these questions that I'll just highlight is that this is really looking at the sustainable nature of the changes that are taking place and then how they've been specifically adapted to the environments in which they're operating. So if we think back to the systems change lens or framework, there's a heavy emphasis on the foundational and sustainable components of whatever change is ultimately taking place. So this next comparison is looking at designing your evaluation, creating tools, and collecting data. So in terms of doing those key parts of evaluation, there are some key differences that you'll want to keep in mind when looking at systems versus program intervention. And so the evaluation is not always, but generally more time limited, particularly compared to a systems evaluation where you have multiple stakeholders that are involved. So when looking at the program intervention, the actual lifespan of the program could generally be more time limited versus a systems intervention, which might have a much longer window in which you're looking for impact. There is generally also a clear group of program staff and participants with a program intervention. In a systems intervention, there can be a large number of staff, participants, stakeholders, collaborators, and they all could have a potential focus on the evaluation piece or informing the evaluation piece. And then also program intervention could draw, when you're looking at a program intervention, you could really draw on qualitative and quantitative data to answer your evaluation questions. A lot of that depends on your own internal capacity, your time, your budget, and your ability to analyze that information. The piece that I'll point out with systems intervention, I want to call out the particular importance of qualitative data, and this is for capturing a deeper understanding of the actual changes that are taking place and how people and organizations are digesting those changes. You may not be able to adequately capture this, for example, with a survey or even having open-ended questions within a survey. And so it's not to say that you can't use quantitative data when looking at systems change, but qualitative may capture that deeper snapshot of how people are making meaning and organizations are making meaning of the change that's going on. It also might help in terms of answering the question around intended and unintended consequences of work or lessons learned as well. So then lastly, depending on how complex the system is that you're dealing with, there may be a challenge in discerning causal relationships or uncovering what led to a specific outcome or impact. So can all of the outcomes be traced back to one specific intervention, or were there other interventions going on at the same time that could have contributed to certain outcomes? Are there other stakeholders who are working to achieve the same outcomes? And if so, what impact did they have? So this issue comes up when you have multiple groups, multiple organizations working on a systems change effort. Really, when you think of things, for example, at a state level or federal level, this is really where this challenge could come in terms of, who is causing what, and looking at whether something is attributing to a change or there's just contribution going on. And so it's good to just keep that in the back of your mind and the difficulty that you might encounter with that, and to really have intentional conversations with stakeholders, with people who are designing an evaluation, to think about mapping out or discussing what those causal relationships can be. So to circle it back to the Ohio case, we thought of some potential data collection activities to answer the future evaluation questions that we shared. So one could be key informant interviews with representatives from family medicine practices who had gone through and who really had time to digest the changes that they had put into place. The other one could be surveys with representatives from family medicine practices. The program could also engage in focus groups or group discussions with key program partners, stakeholders, or decision makers. This would, again, to be able to try to get at both those intended and unintended consequences, and to really unpack potentially some of the murkiness around the overall impact that the program is having at these higher levels beyond just the immediate practices. And then the other piece would be additional data collection regarding practices screening rates. And so for the Ohio case, they could use the online module again if they wanted to, or think of some other ways to capture practices screening rates and the impact that they've had a year or more out after going through the program. Again, with all of these methods, there are pluses and minuses, or negatives and positives that you want to weigh. So key informant interviews and focus groups, you can have a high response rate. There's flexibility in order of asking the questions. You can explore topics at greater depth. And in the case of focus groups, there can be some rich interaction that's taking place, which may be beneficial in this case. The focus group or group discussion could also be very important for identifying some of the other ripples that are happening as a result of the work, and having people really share from different perspectives of interacting with the program what the impacts are going to be. Surveys, again, thinking about capacity, they're relatively easy and expensive, They collect information from a large number of respondents, and they're easier to analyze than a lot of the qualitative data. However, there is a low response rate, or there can rather be a low response rate depending on how the survey is administered. There can also be a challenge to writing good questions, and so those are just some of the other pieces that are key to have in mind with this. And of course, it's always important to select a method that's best suited to organizational capacity, to budget, to expertise that an organization brings, and the one that will ultimately help you answer your questions. And the other piece, too, just to go back, that I want to highlight is when you're thinking about internal capacity, too, is the data analysis component of the work, and whether this is something that can be done internally or externally. Looking to the example from Ohio, there is some internal analysis that they were able to do with their initial evaluation findings, and they may have that capacity built in, but that's just another piece to think about. And the evaluation toolkit can take you through some processes to help you think about that. So in terms of reporting evaluation findings, there are some ways that the Ohio Colorectal Cancer Screening Improvement Program could report their data. And thinking about how they would use this data if they collected it, the primary audience for this work would likely be healthcare professionals, funders, policymakers, so individuals who really are looking for quick pieces of information to easily digest it. And so there should be a focus on clear and short and concise reporting. And so here are some examples that could be used, such as lessons learned briefs, executive summaries, either summaries standing on their own or summaries of larger reports, handouts with bullets, or more formal presentations that pass this information along. The key piece here, again, is to think of the audience and stakeholders who are the target for the report, and needing to balance how much reporting can be done along with capacity as well. And so the other piece that I'll highlight here is the potential use of the evaluation findings. The staff who were administering the Ohio Colorectal Cancer Screening Improvement Program, they really thought of multiple ways that they would potentially use evaluation findings if they were to take it to this next level. And a lot of it revolves around sharing this information back with key audiences and key stakeholders to really digest it, to make sense of it, and to help inform the system overall, particularly for those practices that are not as closely familiar with the work or involved with it. So sharing findings with family medicine practices, sharing information with public health officials and hospital and health systems would be another key piece. Inviting other stakeholders to comment on the findings as well. And then also hosting conversations about incentivizing or performing practices based off of that initial assessment of their colorectal cancer screening rates. And then also using findings for additional evidence for supporting the program. The piece with this that, and this isn't just important related to systems-related evaluation work, but also just program-based evaluation work, is the sharing back of the information. If it just sits there and is not used, that's not helpful. And then particularly with systems-based work is it's good to really share this more widely so that people can also make meaning of this work as well. And they can really help inform this as it continues to evolve, and potentially have other ideas for how it can be used as well. So this slide, it offers a brief summary of some considerations when evaluating systems change work. And again, this is not an exhaustive list, but there's some good kind of food for thought here that I think is helpful. So the first is there are multiple systems at play, often during a systems level intervention. So it's important to be clear based on either a logic model or theory of change or some articulation of goals and objectives, whether the work is systems-based, and if so, which systems are being impacted, and then what do you want to focus on through the evaluation? Because again, this can, depending on how complex an initiative is, can easily sort of spiral out of control in terms of asking a lot of questions and in getting information from multiple stakeholders. So it's important to really take the time to think about that, to digest it, and then to move forward with your work. Another way to think about this too is prior to the process of actually designing evaluation questions, you could also think about doing some exploratory work to just gain a sense of, okay, so who are all the players within these systems that we are potentially impacting, and how do they align with outcomes that we might be producing, and should they be part of our evaluation work moving forward? But to sort of think and test the waters first before going into a formal design. It's also important to understand who the various stakeholders are as part of the intervention that is being applied to the system. So in the case of the Ohio program, there are multiple people involved who design the curriculum, who carry out the training, who work with the practices, who are working in other parts of the Academy of Family Physicians. There's other partners and stakeholders who are working at a public health level as well. And so you'll want to take stock of all of this and then think about, again, either when to bring them in terms of the design process or how to involve them in collecting data. And this gets into the next point about collecting data from multiple sources. Given the multiple stakeholders and groups that are involved, it's important to test your assumptions and to help triangulate different accounts from different people. Again, this is where qualitative data could come in particularly handy with that work. Quantitative data can also work as well, but it's about really capturing those different perceptions of the work. And then because systems change can be complex in nature, there can be, again, this focus on unintended impacts, intended and unintended, and of course, the intended ones are easier to depict, and it's the unintended pieces, both positive and negative, that you'll want to make sure you ask about. And these are the other ripples that you may have not predicted occurring at all, but they may be having some sort of influence on the work. If we go back to the Ohio program, we see that the program itself has started to influence, in an initially unintended way, the way that the Academy is doing its education, training, and outreach. And so it's fundamentally impacting that work now because of the successes that it has shown. And so this is another key area where you'll want to gauge both those sides of impacts. And then the last one is a key focus on gauging sustainability and durability and modification of a systems change as well. So a key element of systems change is this piece about sustainability, and that changes are really meant to be ongoing. It's not meant to be a short-lived intervention. And then the other piece along with this is that it's important to focus on modification of a change as well as it's implemented. This is really where you get good information, good data about how different entities are digesting this change. And then that information can help and inform the overall system in terms of the work moving forward. And so it's key to building questions along that line in the evaluation design. And then the other piece that I just wanted to highlight, I don't know if I made it clear earlier too, is that when we look at the Ohio case, it is also affecting patient outcomes and colorectal cancer screening rates. It wasn't clearly or depicted as clearly in the logic model example that I had shown, but that impact is also going on, which is similar to a program level impact. With the systems level one, though, there is that higher level change to practices and procedures that is ultimately trickling down then to the individual level. And so that's the other key piece that I just wanted to make sure to also share as well. So that is everything I have, and I'm going to hand it back over to Heather now for some questions.
All right, thank you very much, Nick, and thanks to you as well, Kate. Just as a reminder, if you have a question, please type your question into the box in the lower right-hand corner of your screen. Our first question is for you, Kate. how are the practice teams recruited each year? Is there an application process, or could you please tell us a little bit more about how are the practice teams recruited each year?
Sure. Actually, the Ohio Academy of Family Physicians and the Ohio Association of Community Health Centers met to strategize about recruitment, and we really leveraged our communication vehicles within our two organizations to reach our membership through printed materials, our website, direct email. We have an e-newsletter, and those vehicles were also replicated at the Ohio Association of Community Health Centers. There is an application process, and we basically opened it up to the first 20 practices that register, and that has been successful over the past few years.
Excellent. Thank you for that additional information. All right, this is a general question, and Kate, you or Nick can please chime in on this. And Nick, you discussed some examples of measurable indicators of whether or not practice change has happened. Could you elaborate on additional indicators of practice level change, practice being one of the systems of relevance for colorectal cancer screening? So any more thoughts about potential indicators?
Yeah, so I think this would, this is an area where, Kate, I would, if you want to jump in as well, because you have a bit more of the technical knowledge about the implementation, but, some of the key pieces that we're looking at are, getting back to, again, the modification or change of that, the modification of the actual change in protocols that practices are using. Thinking about, so when you have employees who will ultimately be moving on, or you have a shift in staffing, what do you have in place to train them in? So is there durability that's built into those protocols then moving on to the next set of employees? Another piece would be that I could think of just off the top of my hand is surveying people as well. So surveying practice members, and you could think about doing this, a year out or longer, regarding their opinions about how that protocol is actually being implemented, and is it being done according to the standards that were set out originally? Are they finding that it's easy to do? Are they seeing the impact themselves? And so I think there's a variety of ways to sort of break down that overall question about, was the protocol maintained, and if so, was it changed in any way? You can think about doing it along those lines as well.
So that is sort of indicating that beyond just putting a policy in place or putting in place a change on the practice level, whether or not that stays in place, how it's meant to continue after perhaps a single individual moves on. So those are all different examples. Kate, yes. Did you have anything else to add?
Well, anecdotally, I can share that the Ohio Academy of Family Physicians has other quality improvement initiatives, and it's been our experience that practices that have engaged the team training component and then used the module are very likely to register for a different quality improvement initiative. For example, we have a hypertension QI initiative, and we see a lot of practices that come back because they actually enjoyed the team bonding experience and the opportunity to work outside the office to really hone in on making their practice more efficient and to really capitalize on the opportunity to fortify their communications together. So it's not necessarily something that impacts colorectal cancer longevity, but it does strengthen the whole system in the practice.
Certainly sounds like there's relevance to this quality improvement approach among the members. And Kate, a follow-up back to you. You described how the practice teams were recruited and the process of doing so. How many register each year? Are you at capacity, or are there always spots available? That was a follow-up question asked of you.
Sure. Last year was the only year we didn't have fill to capacity. and we're not exactly sure as to why that's the case, but every year before, we've either met capacity or we had to put people on a waiting list.
All right, thank you. And, oh, go ahead.
Nope, go for it.
All right, and circling back to you again, Kate, has the work of the Ohio Academy of Family Physicians been published?
Officially as a white paper, no, but it has received national recognition for our program, both by the American Cancer Society and then as a recognized presentation that was offered at the Dialogue for Cancer Conference in 2013. So we are sharing the story as much as possible. Other health departments in different states have contacted me about replicating our program. So maybe we don't have necessarily a white paper to draw from, but always willing to share actually the actual material and anything that would help other teams or organizations replicate what we're doing.
And somebody could get in touch with you for that information through Mary at the roundtable. Is that fair to say? Or to contact
absolutely.
You?
Or directly, absolutely.
All right, great. And sounds like a real opportunity for you to think about a white paper or some type of a report or maybe another toolkit of some type as well, given your success. Let's see. A question here about establishing baseline screening rates. The question is, did you have any difficulty with establishing baseline screening rates, with the challenge of screening not necessarily being annually or potentially having limitations in electronic health records?
I can attempt to answer that. I'm not as familiar with the inner workings of the module, other than to know that to qualify your chart, there is a rigorous process for which patient chart would qualify. So based off age and family history, your one of 10 charts is entered into the module as your baseline. And then within that 3-month period, you then pull your secondary measurements of people who have been seen within that period or within that intervention that you have put in place in your practice. For example, a practice could choose to identify all members of their practice that qualify for colorectal cancer screening and put an intervention in place that maybe has their front office staff contact each person. Within that group, see how successful they were. So their baseline and secondary measurement make sense clinically.
All right, thank you. And we've actually reached our limit. Time limit, excuse me. We're going to turn things over to Mary Dorshank here in just a moment to give some thanks to our speakers for today and share some additional information with you. And I especially want to thank Kate and Nick, as somebody who does this type of work, for providing us with such excellent background information and then sort of a case study approach here to better understand systems evaluation. So thank you, and I'm going to turn things over to Mary Dorshank. Take it away, Mary.
Yeah, so that was excellent. I learned so much. So Nick and Kate, thank you for those excellent presentations, and Heather, appreciate your help with the moderation of the call, and thanks to all of you for making the time to join. And lastly, we do want to acknowledge CDC, which provided funding to make this webinar possible. We do have a couple more webinars coming up that we want you to be aware of. We did have to move the time of the webinar on exemplary programs within primary care. So we have a wonderful speaker lined up, Dr. Jason Crawford, but we did have to move the October 20th date, so watch for a new date in November to be announced soon. And then we have locked in a date for a webinar on C5 New York City's Colorectal Cancer Coalition on December 10th, so please mark your calendars for that one. And then other than that, just feel free to follow up with any questions by email. We'll try to get the replay out and the slides out to all of you, as well as any remainder questions within the next day or two. So thanks, everyone, for joining.